I'll be discussing the cleft palate this morning. The cleft palate is a congenital anomaly in which there is an abnormal communication between the oral cavity and the nasal cavity. And this abnormal communication is characterized by a defect in the bone, the mucosa, as well as the overlying, as well as the muscles of the soft palate. Neurology of the palate. The primary palate develops separately from the secondary palate. The medial nasal process, the lateral nasal process, and the maxillary process contribute to the development of the primary palate, while the secondary palate is developed from the two palatal shelves. Fusion of these two palatal shelves starts from the incisive papilla and goes towards the uvula. So it's in an anterior-posterior direction. And this explains why we don't have a cleft of the hard palate. Rate of fusion of the hard palate is slower in females than in males. Hence, the higher incidence of cleft palate in the female. This picture is showing the medial nasal process, the lateral nasal process, as well as the maxillary process. They contribute, as I said earlier on, to the development of the primary palate. So fusion of these processes in the midline will form the primary palate. The secondary palate, initially the palatal shelves attain a vertical dimension, vertical position. And then as the tongue descends into its position and mandible continues to grow, they assume a horizontal position and they now fuse in the middle of the palate to form the hard palate. Dilation in the presentation of cleft palate. It can occur in association with the lip, in which case we are going to have the lip alveolus. It can occur alone. We have cleft of hard soft palate, and there are two types of this one. We have the syndromic type and we have the non-syndromic type. The syndromic type are two types. One is associated with an additional structural abnormality that occurs outside the region of the cleft. That is, you can have other abnormalities either on the hand, in the feet, in the abdomen, or in the heart. And the other type is the one in which is associated with a syndrome, with a non-known genetic etiology. There is now a current concept on the terminology of non-isolated cleft palate and isolated cleft palate. The term isolated cleft palate is now reserved for those cleft palates that occur without any other recognizable anomalies, whether it's a syndrome or whether anomaly in the heart or in the leg or anywhere. So it's just the cleft palate and cleft palate alone. So the term isolated cleft palate is used for those ones, whereas the non-isolated cleft palate is for those that have other structural anomalies outside the region of the cleft. And these ones, they don't have any other known genetic etiology associated with them. Cleft palate can also be bilateral or unilateral. And we have cleft of the soft palate and cleft of the submucous and a submucous cleft. These pictures are showing the different types of cleft. Can you see my cursor, please? We have the...
Please do. Please do.
Okay. We have the submucous cleft. We have cleft of hard and soft palate. We have a unilateral cleft palate involving only one side of the palate. And we also have the bilateral cleft palate occurring in association with cleft of the lip. The outline of the cleft can either be V-shaped, or U-shaped. And these shapes also have some implications in the surgery because the V-shaped will be much easier to close than the wide U-shape. Also, the cleft can be wide and then it can be narrow. This picture is showing cleft of the isolated palate. So this is the cleft, an isolated cleft palate occurring without any other anomaly. And this one is actually a cleft of the soft palate occurring in a syndromic patient. This picture is only showing that there is another cleft and that it can also be of varying degrees, as we can see that it is on equal size. The submucous palate is a rare variant of the cleft palate, and it is characterized by mucosal defects in which there is a structural anomaly of the palate. In the submucous palate, there is a defective muscular and bony defects, but it appears as if it is normal. And most times it is associated with the soft palate, but it can also occur in the hard palate. It occurs in the hard palate, it doesn't really have any much significance. When it occurs in the soft palate, it has a lot of significance in speech. And most times it can often be misdiagnosed. There are two types of it. We have the overt type and the occult type. The overt type can be diagnosed by three clinical structures. We have a bifield uvula, a V-shaped notch at the back of the hard palate. And this notch is actually an indication of bony defects. While in the middle of the cleft, we have a translucent bluish membrane. And this indicates that there are no muscles in that area. So the muscles are not attached in that area. As we can see in this picture, we have the bifield uvula, and that is a bluish membrane, as well as the occult type. This type occurs in individuals where the anatomic structure will appear as if it is normal, but usually the classical signs are not really visible at first. The patient will exhibit some features of velopharyngeal dysfunction. That means the patient will not be able to speak, but when you look inside the mouth, you will not be able to see any visible anomaly. And it can be diagnosed when the patient actually opens the mouth and you ask her to say, ha. Then you will notice a triangular depression, as we have here. As we have here, in this patient, and then also in this patient. And you can also notice the size of the uvula. In this other patient, you can see a slight depression there, and then the ridge just showing that you don't have muscles around that side. And at times, they can remain asymptomatic until adulthood. This patient actually a patient, and when she came, the only complaint was that she couldn't speak well. But when we opened the mouth, we saw that there is that depression. We could not confirm the diagnosis because we didn't have the means. Diagnosis of the occult submucous cleft. We can use video fluoroscopy, transillumination technique, the use of nasal endoscopy or pharyngoscopy, transoral ultrasound, and magnetic resonance imaging. Now we have nasal endoscopy, so we can actually record this patient and confirm the diagnosis. Classification of cleft palate. There are very many classifications with modifications, and they can simply be classified as cleft of the primary or cleft of the secondary palate based on relationship to the incisive foramen. If the cleft occurs anterior to the incisive foramen, that is a primary cleft, and if it occurs posterior to it, that is a posterior, that's the secondary. And then the cleft can be complete or incomplete. We have class 1, which is just the soft palate. We have class 2, which is hard and soft palate. We have class 3, which is a unilateral cleft lip, alveolus, hard and soft palate. And we have the bilateral, the class 4, which is bilateral lip, hard and soft palate. And for the Kinahan classification, is a classification that is based on embryology because it uses the incisive foramen to divide the cleft into an anterior portion and a posterior portion. And it actually uses a Y-shaped symbol to decide the cleft. And the Y-shaped symbol is divided into blocks. It's divided into blocks. So we have the right and the left side. That is the incisive foramen. We have the lip, the alveolus, and then the primary palate, the hard and the soft palate. But there's another more recent classification which I consider to be more objective, because it helps to make a decision on the choice of the surgery for the cleft. And this was described by some surgeons from Peru and presented at the cleft conference in 2005 in South Africa. And the objective was to correlate the size of the cleft to the fistula formation and the VPD. This classification actually evaluates the amount of tissue that you require to mobilize to be able to close the cleft. So they used the cleft defect. So they relate the cleft defect to the amount of tissue that is available for mobilization. That is the Y1 and the Y2. So the Palatal Index is a proportion of the cleft defect, which is the X, to the sum of the Y1 and Y2. So it's X over Y1 and Y2. The measurement is taken posterior to the hard palate at the junction of the hard and soft palates. The Y is measured at the same place, and the X is also measured at the same place. So with this, you can now classify the cleft as either mild, moderate, or severe. So if it is mild, you know that you don't need too much mobilization for you to be able to get this tissues into the mid portion. So the mild one is going to range from 0 to 0.2 mm, the moderate 0.2 to 0.4, and severe greater than 0.4. So if you look at these pictures, you see that this is a very narrow cleft, and we have this amount of tissue to mobilize into the midline to close this defect. When you look at this, this is moderate. Don't forget that you are going to make your incision along the gingival margin. So the amount of tissue that you have left is just from the incision to the cleft margin. And look at this one. This is actually a very wide one in which you don't have much tissue to mobilize. So you have to think of the choice of the technique that you will use, that you'll be able to close these defects without having fistula. So in that study, they actually found that there is a relationship between the palatal index and the choice of technique, but there is no relationship between the palatal index and the VPD. And this is quite understandable because there are other factors that will contribute to VPD. The normal anatomy of the palate, we are all familiar with this. The palate, we have the hard and the soft. The hard palate occupies the anterior 2/3 and it is bony, while the soft palate is essentially muscle and it is mobile. The hard palate, as we said earlier, is bounded anteriorly and laterally by the alveolar arches, and it consists of the palatine bone and the horizontal plate of the palate. And it has some foramina for the greater palatine, for the lesser palatine, and as well as the incisive foramen. The soft palate is mobile and it ends as the uvula, which is centrally placed. And it also separates the oropharynx from the nasopharynx where it ends. The uvula is the dangling structure in the middle of the soft palate. It continues to also form the try the number, but when you look in the literature, some people include superior constrictor muscle because it also performs a certain function in the velopharyngeal apparatus. So the tensor veli palatini, the levator veli palatini, the palatopharyngeus, palatoglossals, and the muscular uvula. Of all these muscles, the levator levi is the most important in the soft palate. And some of these muscles originate from the palatal aponeurosis, while some are inserted into the palatal poneurosis. As I said earlier, they play important roles in speech and swallowing, and they close up the nasal cavity from the oropharynx. And they are actually attached together as a sling. So most of the time, they are responsible for the speech. Some of them function also in swallowing. The levator velar palatini originates from the temporal bone in the base of the skull, and also has another origin from the sacral tube and is inserted into the middle of the soft palate. The nerve supply for the muscles of the soft palate is from the cranial nerve, from the vagus nerve, except the tensor velar palatini that is supplied by muscles to the medial pterygoid. I just have the origin, insertion, and innervation of the different muscles. We'll talk about them in the anatomy of the cleft palate. If we compare the normal palate with the cleft, we will see that in the cleft palate, there's a defect of bone in the midline, there's defect of muscle in the midline, the subpalatal region, and there's also a defect of the overlying mucosa. In the cleft palate, the arrangement of the muscles is distorted. This is the levator velar palatini, and this is the tensor velar palatini. The tensor velar palatini lies anterior to the levator velar palatini, and they are in a transverse direction, as you can see. But in the cleft, they assume a longitudinal direction, and the relationship of the tensor velar palatini to the levator velar palatini is distorted. The tensor velar palatini is attached behind the hard palate, while the tensor velar palatini is attached along the cleft margin, and they now lie side by side. This is important when we are going to reconstruct these muscles in soft palate surgery. Challenges associated with the cleft palate. Individuals with cleft palate have multiple challenges, and these challenges include feeding, airway, speech and language challenges, dental and skeletal anomalies, orthodontical diseases, as well as psychosocial issues. The feeding difficulties. One of the immediate concern of a baby born, of the mother of a baby born with cleft lip, is aesthetics. That of the cleft palate is feeding. And depending on the severity of the cleft, the baby is unable to successfully suck because he cannot maintain the function, the sucking function, and also because of nasal regurgitation. Most times in the clinic, we find parents bringing their babies either with an NG tube or with an IV line on. And at the hospital where they are born, they usually tell them, don't feed this baby. And when the baby is born for about 3 or 4 days before they come to us, they are not being fed. And this is not right. There are several strategies to overcome these challenges, these feeding challenges. But the most important thing is that we encourage the mother as much as possible to breastfeed the baby. But when she is unable to breastfeed the baby, then she can resort to other measures. In our center, we use feeding bottles. There are some special feeding bottles which we are able to get in the market, or we advise them to use cup and spoon. But we don't advise use of syringes because they find it difficult to maintain a good hygiene with these syringes. You can use the one syringe for quite a long time without changing it, without cleaning it. And in our clinic, what we do is that we educate them at the first visit. We need to educate them on how to position the patient and also how the mother is to be positioned during feeding. And you demonstrate how the feeding will actually take place. If the mother is unable to breastfeed, then you can use the formula. And in our clinic, we add the formula, we boil the water, and we show them, the matron shows them how they are going to feed the baby. The airway challenges. Airway challenges is not so common with children with cleft lip and palate unless there is a coexisting structural abnormality, as we have in Pierre-Robin's syndrome. The speech challenges. Patients with unrepaired soft palate will develop some form of speech difficulties, which is related to palatal insufficiency. And this usually is a concern for the patient, particularly is an important function, is an important. The other component parts of this sphincter is the soft palate, the lateral pharyngeal wall, and the posterior pharyngeal wall. And they actually separate the oral and nasal mucosa during speech and swallowing. Velopharyngeal dysfunction results when there is inactivity of the velum and the pharynx, because during speech, all of them move together. The lateral pharyngeal wall, the posterior pharyngeal wall, as well as the muscles of the soft palate. So the effect of BPD on speech can manifest in different ways. Dental challenges. A cleft of the lip and alveolus, as well as the palate, can produce a lot of skeletal anomalies in the oral mucosa. And these anomalies range from irregularities in the shape of the teeth, number of the teeth, the occlusion of the teeth, as well as mandibulomaxillary discrepancy. These pictures are showing different types of occlusal disharmony that we have. Here you can see that there is crowding in this place. The lateral incisor is not properly aligned. In this patient, the arch is narrowed. The central incisor is rotated. The central incisor is rotated, and she also has the peg-shaped lateral. And in this man, we can see the hypoplasia as well as presence of multiple teeth, supernumerary teeth, in this patient with a cleft, bilateral cleft of the lip. This picture is actually showing the skeletal deformity that you have in a patient with cleft palate. This is a bilateral cleft, and in this case, we can see that the maxilla is behind the mandible, so it's in crossbite, both in an anterior position as well as a posterior position. Pathological problems. Middle ear disorders are common among individuals with cleft palate, and this is a result of a dysfunction of the Eustachian tube. Remember, the tensor veli palatini and the levator veli palatini have attachment to the Eustachian tube, but when they are not properly attached, it affects the opening of the Eustachian tube to drain the middle ear. And when there's no drainage, there's accumulation of fluid which can readily get infected. So this can lead to otitis media with effusion. When there's repeated otitis media with effusion, it can actually lead to hearing loss. Parents of children with cleft palate, as well as the children themselves, will suffer from some emotional, social, and behavioral problems. And this is due to aesthetics, function, and then need to attend the clinic repeatedly. Usually the children may not suffer these emotional and social disturbances until they start to go to school. But the parents suffer this as soon as the baby is born, because they need to care for this baby. And then we have also seen that it can also cause some conflicts within the family. So it is important that we also take this into consideration when we are planning for our treatments. Management of cleft patients. The management of cleft patients is a long-term treatment that starts immediately after birth. As I have said, the baby needs to feed, the patient may suffer that we need to be treated by the orthodontist, and therefore we need a holistic approach with a multidisciplinary treatment for the patient because of the multiple associated problems, as we have said. And this is the list of the multidisciplinary team. In our hospital, we don't have a geneticist. So what are the goals of surgical treatment? The goals of surgical treatment is that we want to separate the nasal mucosa from the oral mucosa so that the patient will be able to speak properly. And also, In doing this, we want to be sure that we are realigning the muscular sling properly to their position so that they can move and create a competent velopharyngeal valve. We also want to ensure that the patient has a maxilla that is properly developed, or that grows properly, because we don't want a constricted maxilla. The implication of a constricted maxilla is that it's going to affect the occlusion of the individual. And we also want to ensure that we improve the auditory function of the individual. Also, when we are performing a surgery, we must have it at the back of our minds that we want to prevent fistula formation. So it's another goal that we need to think about, because it's been said that it is our surgeries that actually contribute more to fistula formation. So the timing of repair. There are two schools of thought on the best time to repair the clefts. And this controversy is actually centered on the concern of the surgeon for proper speech development and also the facial growth. Early surgery, those that believe in early surgery, believe that the speech is going to be improved. But at the same time, if you close early, and when we talk of early, that is before the patient starts to speak, maybe from 6 months to 12 months. But if you close early, then it's going to have an implication on the growth of the middle face. There's going to be restricted mid-facial growth. Those that believe that we should close it at a later age believe that the maxilla is going to grow properly and we will not have restriction. And so we have a midpoint between this. Some people believe that we can repair the soft palate earlier. That's about 6 months. So when you repair it earlier at 6 months, then you can take care of the speech of the individual. And then we can now repair the hard palate at a later date so that the mid-face, the restriction of the mid-face will not be there. So, but it is now believed that even if you close the soft palate at an earlier age, sorry, at a later age, after the patient has started to speak, that it doesn't really have much effect. It may not have much effect on the speech of the individual, because it is not only the soft palate muscles that contribute to that velopharyngeal function. As I said earlier on, you still have the lateral pharyngeal wall, you have the posterior pharyngeal wall, and there may also be some neuromuscular problems associated with it. In fact, in recent times, we have closed the cleft palate in 2 young ladies that are over 20. When they came, the speech was not good. After the repair, the speech was slightly better, but with speech therapy, I mean, the speech really improved. So there's still a lot of control. These are just only 2 patients. I cannot really say that the delayed closure will actually not have any impact on the speech. It's an area that we need to look into. So advantages of early closure. Speech development is enhanced. The patient can feed very easily, and then the mother can even go about her normal duties time. There's better auditory function, the oral hygiene is improved, and there is improved psychological well-being for the mother and the child. The surgical techniques. There are very many surgical techniques with various modifications. We have the von Langenbeck's technique, we have the Vohwinkel pushback technique, Bardak's 2-flap technique, fellow double opposing Z-plasty, intravelar veloplasty, use of the Vollmer flap, and the buccal myomucosal flap. I'll take them one by one. The von Langenbeck is actually the oldest, and I consider it to be the simplest method, and it's actually good for beginner. When you want to start trying to close the cleft palate, it's how you start with the von Langenbeck. And it is actually a bipedicle flap. We make incision around the cleft margin. This incision around the cleft margin is going to enable us to develop the nasal mucosa. So when you make it on both sides of the cleft, then we are going to mobilize it into the middle to close, to create the nasal mucosa. You do it right down to the soft palate, and also make a lateral incision along the gingival margin on both sides. This is going to create the flap that we will use to create the oral mucosa. From the hard palate, we close only in 2 layers. We close the nasal mucosa as well as the oral mucosa. But in the soft palate, we are going to close the nasal mucosa, the muscles, as well as the oral mucosa. It's actually a bipedicle flap that is based on the greater palatine vessels. In this technique, it is important that we try as much as possible to release the soft palatal muscles. This is one of the disadvantages of von Langenbeck, because if it is not properly done, then you will not be releasing the muscles. And it's important that we release the muscles. If you make the incision like this, when I first started, I usually make my incision like this. But I discovered that with this incision, it will be difficult for me to get access to the muscle, particularly the tensor veli palatis that is on the hamula. So now we'll make the incision, there's a depression just posterior to this axillary ridge. So we make the incision vertically, so that with this, by the time we make the incision and dissect, we'll be putting an instrument on the hamulus, and then we can release the muscle. So one of the disadvantages is that it doesn't really correct the muscles very well. But with improvement, it can actually be done. It is not advisable for wide clefts, because you have a pedicle here and you have a pedicle here. So it may be difficult to actually move it. And it's one of the reasons why we usually have fistula, particularly in the anterior region, when we use this technique. And then the other thing is that after the closure, we have a raw surface on the lateral margin, on the margins of the gingival margin of the maxilla. This one we usually pack. You can pack with Sofra tool, and then you remove it after some time. It's actually going to granulate after a while. And then, as we said, this can also contribute to the restricted growth of the maxilla, because we are going to have a scar here that is going to heal by secondary intention. And to some extent, it extends or elongates the maxilla, but some people, I'm sorry, it elongates the palate, but some people say it doesn't elongate it as much as we want. But with this one, you may not be able to realign the muscles very well. So this is a picture of a cleft palate, not too wide, and this is the end product of the von Langenbeck's technique. This is the defect from the lateral incision, which is usually packed with. So we have the VY procedure. This has actually been abandoned, and it is a modification of the von Langenbeck technique, and it is very similar. The difference is that in this technique, we are going to connect the lateral incision, the cleft incision around the cleft with this line and with this. So we are converting the V into a Y. And then we are going to move this all down. We move it right down to the soft palate, as you can see. So when you move right down to the soft palate, then you'll be able to close the soft palate. And then at the end of the day, when you finish closing the palatal mucosa, you are going to be left with this defect. You can see how wide the defect is. And the reason why it is abandoned is that it actually restricts the growth of the maxilla, because you have quite a large raw surface that is going to grow by secondary intention, and is going to lead to scar formation that is going to cause restriction of the maxilla as the child grows. So it's really no longer popular. Vaginal two-flap palatoplasty. This is actually, as I said earlier on, all of them are modifications of the Lagenbeck technique, and it is two-flap. In this one, you can still make incision around the gingival margin. And then, in this case, we are going to connect it to the paragingival margin incision, so that you'll be able to suture the two sides together. If you have the vomer in bilateral, we can make use of the vomer flap, in which case this will help us to close the nasal mucosa. So you raise a flap here, get mucosa to this side, you get the mucosa on this side to this side, so that you'll be able to close the nasal mucosa. You do the same thing here. And then for the oral mucosa, you're going to lift this flap up, and then you'll now be able to close it with this. This one actually improves length of the maxilla, and it also gives you the opportunity to also realign the muscles of the soft palate. The follows double opposing Z plastic was initially described for primary closure of the palate, particularly the soft palate. It is meant for the soft palate, and it uses two opposing triangles. If we look at this picture, there's a triangle that comes from the tip of the cleft of the soft palate, and it goes towards the tuberosity of the maxilla. This flap is going to be inferiorly based. We are going to radialize so that it's inferiorly based. The one on the right side is going to be superiorly based. This flap will only contains the oral mucosa, whereas this one that is inferiorly based will contain the oral mucosa as well as the muzzle. So this is what we have. Now, when we have raised that flap, we now have beneath this flap, you have only the nasal mucosa, and beneath this flap, you have the muzzle as well as the nasal mucosa. So we are closing. We are now going to make the incision in the opposite way that you make this one, so that this flap that contains only the nasal mucosa is going to be superiorly based, and this flap here that contains the muscles and the nasal mucosa is going to be inferiorly based. And then we are now going to transpose, so it will now give us a double triangle. And this one actually extends the soft palate very well. And it also improves the speech of the individual. Now it has been reserved for secondary repair of the palate. In fact, Smart Tray now considers it as a BPD surgery, because it is said that if you use it for the primary repair, and then you now have issues with the speech of the individual, then it may now be difficult for you now to be looking for other methods to improve the attachment of the muscle. So it's essentially for the soft palate and for secondary closure. Well, it may be technically challenging because suturing this mucosa and the other one may be a bit difficult. And at times you may need to make a small incision, a longitudinal incision posterior to the mandibula, so that you'll be able to move the flaps so that they can close at the middle. This is one that we did. You can see that the palate cleft is actually narrow, and this is the double opposite triangle, one triangle and the other triangle. And from my experience, it actually elongates the soft palate, and also improves the speech of the individual. The buccal mucosal flap is actually used as an adjunct to some of these that I've mentioned, particularly when the palate is short, and it is based on the buccal artery, the facial artery. The flap can be posteriorly based, anteriorly based, or superiorly based. And the good thing about the flap is that it is quite thick, because you are also taking the buccinator muscle with it, as well as the buccal mucosa. So it can also help where you don't have a nasal floor, as you can see in this place. In this picture, you can see that the palate is very short. The soft palate is very short. And then when you put this, when you use the buccal myocutaneous flap, it can actually help to lengthen the palate and also provide some muscles for movements of the hard palate. And the donor site is usually closed primarily, and it doesn't leave any raw surface. There's no need for any lateral incision or lateral incision, so there's no fear of having a restricted growth of the maxilla. How do we assess all surgeries, the outcome of surgery? Venopharyngeal insufficiency is one of the ways to assess the outcome of the surgery. The midfacial growth retardation, as well as palatal fistula formation. The venopharyngeal insufficiency can actually be assessed in the clinic, clinically to some extent. When we finish our cleft, at the next clinic, we try and ask the patient to open the mouth to say ah, and we will actually watch for the length of the palate, though this is not objective, where you don't have the necessary equipment. So you ask the patient to open the mouth, you look at the length of the plate, is it elongated or not? And then importantly, you ask the patient to say ah. So you look at the soft palate muscle, are they moving? If they are moving, then maybe you may not have much of palatal venopharyngeal insufficiency. But the best way to assess this is the use of nasal endoscopy, which we have just acquired. And now we are actually recalling our patients, so I will now be able to assess whether our procedures have actually served the purpose or not. But without it, we cannot really say objectively whether that technique we have used is okay or not. But it's always good to assess our surgery as soon as we finish, maybe 1 week, 2 weeks after the surgery. I'm just asking the patient to open and close. And where we have the speech providers, we usually bring them in. We usually bring them in to assess. And then they'll be able to tell us whether there is insufficiency or not, or whether the patient will benefit from a secondary repair or cannot benefit from a secondary repair. The mid-growth retardation cannot be assessed as soon as the patient, it cannot be assessed immediately. It can only be assessed when the patient has grown to a certain age, maybe probably about 5, 6 years. And at this time, you'll be able to assess the arch of the individual, know whether there is restriction or there is no restriction. The palatal fistula, we can assess this one as soon as the wound heals. And palatal fistula, there's communication between there is an oronasal communication. And at times, you can have dehiscence. If there is a dehiscence, then that is going to after some time. In the dehiscence, the nasal mucosa is actually intact, but the oral mucosa as well as the muscle are not really in the midline. So, in conclusion, the knowledge of the anatomy of hard and soft palate is important in the repair of cleft palate and prognostic view of surgical outcome. And any method that we are going to employ in the repair of cleft palate should aim to reestablish the muscular sling of the soft palate to enable proper speech development. Further studies may have to be carried out in our environment on the appropriate means of repair of cleft palate. Thank you very much for your attention.
Thank you very much, Professor Ogunlewe, for the wonderful lecture. For those who were not here at the beginning, this lecture was on cleft palate and cleft palate repair by Professor Ogunlewe. I will say that the greater majority of the house appreciated your lecture and have some questions and comments. Are you with me?
Yes, please, I can hear you.
So let me start with the first question. Please kindly explain the sex differences among cleft palate patients.
I should explain what? Sex difference?
Yes, among
Okay.
the cleft palate patients.
Okay.
And then 2, does cleft palate affect hearing?
Does cleft palate affect hearing?
Yes.
Okay.
And then I will stop at this number 3 so that you can take them. The third question is absence of feeding bottles and syringes.
Okay.
Though it's not advised, what other options are there to measure in intake?
Okay.
So let's start with these 3. I will then move with the others.
Okay. The first one, the sex difference among the cleft patients. You know, when I was talking about the embryology, I said the closure is a bit slower in females than males. It closes 1 week after the females, after the males in females. And this is why you have a higher incidence of cleft palate in females than males. The other question, does cleft palate affect hearing? Yes, it does. I mentioned the attachment of the tensor veli palatine as well as the levator veli palatine to the eustachian tube. If they are properly attached to the eustachian tube, it prevents drainage, the opening up of the eustachian tube, so that fluid will accumulate in the middle air. And when the fluid accumulates, it can get infected. So recurrent accumulation, which leads to otitis media with fusion, can also lead to hearing loss. The other question on feeding bottles. How do we measure? Or what did you say?
Yes, the absence of feeding bottles and syringe feeding is not advised. What other options are there to measure the intake?
The intake, you can have the graduated cup.
Okay.
You know, the baby cannot really suck very well. So what you advise is the mother should actually pour the milk, put it in a graduated cup that can be measured. You also use the syringe to actually measure, but we don't advise use of syringe to feed the babies. If you use the syringe to measure, you can pour it in a cup or you can pour it in a bottle. And most of the bottles, they're actually graduated, so you can actually know the amount you are giving the patient. But why we don't advise syringe is the level of cleanliness, because they cannot clean it very well unless you want to be giving them 1 syringe per meal or 1 syringe per day. So that's why we don't at the center encourage use of syringes. I know some centers use it. We do well with cup and with feeding bottles for our patients.
Thank you so much. So let's go to the fourth question. The fourth question is, does cleft palate increase the risk of otitis media and airway infection? Are you with me?
Yes, please, I'm listening. Does cleft palate increase the risk of
otitis media and airway infection? Then number 5, can the Palatal Index be assessed preoperatively to guide choice of technique?
Okay.
The Palatal Index, please. Then number 6, is there a reason why recurrent urinary tract infection were not considered as part of problems and challenges you mentioned?
Okay.
And then 7, as concerns the Palatal Index classification, do you have a particular technique to tied to mild, moderate, and severe types.
Okay.
So let's answer these ones.
Okay. He said, does Cleft Palate increase the risk of otitis media? It's been shown, I mentioned it earlier, it's been shown that it is associated with this, and it can actually increase the risk because there isn't a proper drainage of the middle air. But that may have to be subjected to some research to know the level of risk. The palatal index, yes, the palatal index, you have to measure preoperatively, but it is not easy to measure it in a young child. So you have to measure it at the table, at the operating table. So when you measure it at the operating table, that is the only time you'll be able to know the values and the proportion of the X and the Y plus, and the Y1 plus Y2. I hope that answers that question. I think there's another one, palatal index.
Yes, do you have a particular technique tied to mild, moderate, and severe types?
As I said in my presentation, I said the mild, von Langenbeck is fairly good for the mild. You can also apply it probably to the moderate one, but with the moderate one, we'll do well with the Badak two flap technique. But for the very wide ones, you may have challenges using any of these methods. And what some people advise, you can actually close the soft palate first and then close the hard palate later. And we have actually tried, when we close the soft palate first, we find out that when we come back to close the hard palate becomes so easy to close. The palatal defect is now reduced and it is easy to close. You say, is there any? You said,
is there a reason why you did not consider recurrent upper respiratory tract infection as part of the problems and challenges?
Well, it can be considered as part of, but we don't often have it, and you may not even have it if you're able to feed the baby properly. Because what happens, what is really responsible for this upper respiratory tract infection in most of these children at times is when there is regurgitation or aspiration while they are feeding. If they're able to get the feeding techniques very well, then this will reduce the risk of upper respiratory tract infection, unless the child has some other accompanying problems.
Okay.
Does that answer the question?
I guess so. Let's go to the next question. In considering the timing of repair, shouldn't a case be made for delayed repair in patients with Piri-Robbins sequence?
Delayed repair.
For the patients with Piri-Robbins sequence. Yeah.
Actually, Piri-Robbins sequence, I think that's the ideal thing. At least for the cases that we had, because number one, if the baby is not properly developed and you are trying to repair the cleft, you may have some anesthetic challenges. Even with the one that we have done, the baby was almost well over 1 year, I think close to 2 years before we were able to repair. You need to allow the patient to stabilize. And where we are able to actually distract the mandible, we may consider distracting the mandible first before we actually repair the cleft palate.
Thank you. Now, some people believe that repair of cleft palate has no significant value. It doesn't add any value to the quality of life. What are your thoughts?
If a patient is not able to speak properly, it's going to affect him emotionally. It's going to affect his social interaction. So to me, I think you can say that for hard palate, but not for the soft palate. It is going to affect the quality of life of the individual, because when the baby grows or when the child grows, you cannot mix very well with your peer. They'll be making fun of you the way you speak, either you are speaking through the nose or they cannot even hear you. And we've also had adult patients with cleft palate that come to clinic. They actually come either when they want to start to work and they cannot interact very well. They go for the interview and then they notice that something is wrong with them, that is when they now come to the clinic. I believe it will affect the quality of life of the patient.
Okay. Thank you so much. Now, when do you consider operating on patients with submucous cleft?
When the patient, most of the cases of the submucous cleft that we have had, they did not come as a child. So as soon as they come, we repair it. The same way the same protocol we want to use for cleft of soft palate, because it's already affecting the speech. If the baby comes before it has to speak, I think it is better we repair at that time. But if it's coming late, then you do it anytime the patient presents. But if the patient presents to you earlier, then we do it before the patient starts to speak, because it's going to have the same effect on speech as well as what the overt type is going to have.
Okay. Thank you so much. Is there a need to fracture the pterygoid hamulus so as to move the flap medially in von Langenbeck's repair?
That was what was done in the past. In fact, that was what my teachers taught me. But now we find out that it is not necessary. The most important, that's why I talked about that incision, that vertical incision posterior to the hard palate, to the alveolar ridge. If you make a vertical incision, you'll be able to have access to the tensor veli palatini, and you'll be able to dissect it off the hamulus. So you'll be able to move it. So you don't need to fracture the hamulus. And I think it is not done any longer. The other way you can mobilize your flap very well is to skeletonize the greater palatine. If you skeletonize the greater palatine, it will allow further movement of that flap. So it's not fractured any longer. Can you still hear me? Hello? Hello?
We can hear you, Professor.
Oh, okay. So I hope that explains the fracturing of the hamulus. I can't hear you.
I think our moderator has lost connectivity, so I'm trying to see if there are any questions that were not. Oh, Professor Philip is picking up. Okay.
Good morning, Prof.
Good morning, sir.
I will just fill in the gap for Professor Ekenze and Professor Shalbwala.
Okay.
And I will try and find out. I may have to bunch your questions so that we can. I want to find out exactly where he stopped. But even if I don't get there, I will just take it from the next one. Yes, he said, I'll take you 3 questions, then you respond.
Okay.
He said, for aesthetic safety in our environment, in this sub-region, shouldn't repair be considered as from the age of 10 months earlier, 10 months and thereafter? Can't we consider repair thereafter? And then for the soft palate only, when a patient has only soft palate, what technique do you prefer? Bada or follow? And the last one for now is, this one is a very long one, so I'm sure you may not take it. It says, kindly describe the intravelar veloplasty. I think that may take a long time, so we can leave that. So just respond to these 2 while we sort out the other questions.
Okay, about the aesthetics. Sir, can we consider repairing the cleft palate after 10
months? Yes, especially in our environment.
After 10 months, yes, we can. The aesthetics is not really involved in this case unless the cleft palate is in association with the cleft of the lip and the alveolus. Aesthetics is not really the main problem here. Function is the main problem. And the function we are talking about.
Excuse me, Prof. We're talking about anesthetic safety. Anesthetic safety.
Anesthetic safety.
Yes, please.
Well, for anesthetic safety, the patient once you make sure that your patient is fit and anesthetist is happy with the patient, then there's no reason why you cannot do it before 10 months. And we do our own actually at 1 year. But the other challenge doing it before 10 months is that you may not have adequate tissue to mobilize. The tissue may not be full enough for you to mobilize. That's the only thing you have against doing it at an earlier age. For soft palate only, follows procedure is actually better for soft palate only. But like I said, if you use it as the primary surgery, then it will be difficult for you to use it for secondary repair. In your choice of using follows, you have to be sure that you consider the size of the cleft before you use it. For BADAC, we can also use it. The most important thing is the mobilization and the rearrangement of our muscles. Remember, the tensor veli palatini is attached to the hard palate. We have the hard palate. So when we make an incision around the cleft palate, trying to make to correct the nasal floor, you need to release the muscle right from there. And also you release the tensor veli palatini from cleft margin. And then you release them right down so that they are mobile around the cleft margin and the incision around the gingival margin, and you don't do anything to the muscles, then you are not correcting the attachments. So we can use BADAC, we can use the result as a secondary repair and consider that as a VPD surgery.
Okay, thank you very much. We'll just take two more batches. Hello?
Okay.
We'll just take two more batches of questions.
I can hear you.
Yes, we'll just take two more batches of questions because we need to round up. So the first 3 questions in this batch.
Okay.
You said there is no need for lateral relieving incisions when the buccal myomucosal flap is used. Are you suggesting that the BMF cannot be used in combination with von Langenberg or Bacher's lengthening of the soft palate? That's the first question. The next one is, which repair technique has the highest fistula rates? Then, in a second stage palatoplasty, is a second stage palatoplasty beneficial in an individual with a severe cleft due to an increased palatal index? And what would be your preferred surgical technique? Can you answer this? Prof. Hello, did you get those questions?
No, I did not. Please, can you come again? I did not. I was off.
Okay, fine. I will just rephrase them and then go through. They say, what's the highest, what technique gives the highest fistula rates? That's the first question.
Okay.
And the second question is, let me look for the second question. In a two-stage palatoplasty, is a two-stage palatoplasty beneficial in an individual with a severe cleft due to an increased palatal index? And what would be your preferred surgical technique? Okay.
The technique with the highest fistula rates, it is often said it is the von Langenberg that is associated with high fistula rates. But I believe that even with von Langenberg, the fistula rate can be reduced, and this is where the skill of the surgeon comes in. And then using if you use the appropriate, use the palatal index, and you choose the technique appropriately for that cleft. If you have a very wide cleft and you want to use von Langenberg, definitely you are going to have a high fistula rate. So you have to be careful of the choice and ensure that there is no tension. I have observed that what is responsible for the fistula rate in my center is inadequate mobilization of the flap. So we have to think of the size of the cleft as well as the technique. The other is a two-stage palatoplasty with a severe. Sorry, what's the question about the two-stage palatoplasty?
Is a two-stage palatoplasty beneficial in an individual with a severe cleft due to an increased palatal index? How to be your technique in this situation?
As I said, I would rather prefer to use a two-stage palatal technique. I will want to close the soft palate first, and then the hard palate will be easier for me to close. And then at times we may need to use the buccal myocutaneous flap if it is very wide, because it will be difficult for us to actually approximate because there is really no tissue to move about. So the buccal myocutaneous flap is going to augment whatever procedure we are going to use.
Okay, thank you very much. We'll just take the last batch. There are still the questions are so many, a lot of interest, but time is running out.
Okay.
So the last batch, 3 questions. What age do you measure early speech outcomes and VPD? That's question number 1. Question number 2, do you have any experience in prophylactic insertion of grommet tube and meningotomy to prevent hearing loss?
Okay.
And then the last question, which I will take, there's really so many. What do you consider enough time to delineate between a dehiscence and established palatal fistula?
Okay.
There's a tricky one here. If you can just put it in. It says, can you give a word on? Okay, fine. Can you give a word on few tricks on the detachment of the muscle from the vertical orientation in cleft?
Can I give what? Can I give what?
Just? I think this one is really maybe technically demanding. I'm sure later we can post the answer later when we consult with you. So please just answer these ones and then we can call it a day.
Okay. You say at what age do we check for early speech? Usually it is difficult to check for speech when the baby is still at 1 year old or 1.5 years because it's just starting to develop speech. So you will not get the cooperation of the child. So most times by 3 years, that is when we actually try to check for the speech. Though they will be coming to the clinic and then refer them to the speech pathology. You cannot get much from them at the time that we do the surgery, which is about 1 year old. They don't cooperate. So they need to do a little bit more to cooperate. You said enough time between dehiscence and fistula. By the time the wound heals, it is usually about 2 months or 3 months, and we will know whether we have a dehiscence or a fistula.
Okay, thank you. The last one, yeah, that answers the question. Thank you. So the last one is about any experience with prophylactic. Hello.
Hello, I can hear you. I can hear you.
Do you have any experience in the prophylactic insertion of the grommet tube and meningotomy to prevent hearing loss?
We have actually done it for a few patients, and we do it at the time that we are closing the palate. The ENT surgeons are the ones that insert it, not us. So I don't do it.
Okay, Professor Ogunlewe, thank you very much. Your lecture has indeed stimulated a lot of interest, technically detailed, very wide and interesting. This series continues tomorrow, same time. We thank all the attendees. We thank West African College of Surgeons and Smile Train for maintaining this teleclef series. Do have a nice day.
Thank you very much.
Thank you very much.